All right, we'll go ahead and get started. Good afternoon, everyone. Thanks for joining us today. I am Trey Lorraines, the State Medicaid Director at the Oklahoma Healthcare Authority, and I will be walking you through today's town hall and all the information regarding our upcoming release of the request for proposal for our Sooner Select product for our medical plans. So as we walk through this, we kind of want to identify, why we're doing this, why are we choosing to go a different direction, what's prompted us to come to this conclusion. Well, as you know, one of our main missions at the Healthcare Authority is to make sure that individuals have access to healthcare regardless of their ability to pay. And part of that is ensuring that our population receives the best level of healthcare possible and that we're actually working towards improving their health outcomes in the meantime. As we look around, we know that the Healthcare Authority, we provide great service. We've come a long way over the last 25 years in terms of care coordination, additional benefits, things that really benefit the health of our members. But as we look at national statistics, we still rank in the top 10 for so many of those conditions that are major health drivers. For example, we are the fifth worst in infant mortality compared to the nation. We have the 10th highest rate of obesity in the nation, 7th highest in diabetes, and 3rd highest in heart disease and related conditions. So we know no matter how good we are doing, we can still do better in all things. And so we have worked closely with, of course, the governor's office, our legislature, both the House and Senate, our provider community as a whole, to really come to a solution that we think is best for Oklahomans and moving forward. And that's why we are choosing to go to a new service delivery model that we are calling Sooner Select. The main difference between how we operate today and how we will operate under Sooner Select model is that we will be contracting and partnering with third-party organizations to administer the Sooner Care program for the majority of the populations that we serve. So going over a few of those goals, I just mentioned where we stand on the list nationally for a lot of our current health outcomes. So we want to improve on those. We are in the minority as states go in terms of how we deliver Sooner Care or Medicaid services called Sooner Care in Oklahoma. We are one of the last about 10 fee-for-service states. The majority of the other states, well, of course, 40 have gone the other way. And we're seeing a lot of improved outcomes in those states. And so it was time for us to look at a different route for providing these services. We want to move towards a value-based payment and away from payment based on volume. As I'm sure most of you are aware, currently, if a provider provides a service to treat a condition, we pay for that service. There's very little, did that service actually improve members' health outcome? Did it move them towards reaching their goals? There's not a lot of that in the majority of our programs, and we want to move towards that direction. Also, first, also at the front of our mind is we want to improve Sooner Care beneficiary satisfaction. Are our members happy with the services they're receiving, not only from their providers, but from the Healthcare Authority as well? We certainly want to contain costs through improved care coordination of services, making sure that members have available services to them at the right place, right time when they need them. And we want to increase cost predictability to the state. Again, in a volume-based business, we are purely paying those claims and there is no ceiling on that. That'll go up and down based on how bad a flu season is, for example. We want cost predictability through capitated payments, and I'll go over that a little more in detail later. So program design, what is Sooner Select going to look like? The key design evolution of this is around a lot of the stuff I'm going to point out today is a lot of the key differences from what I'm calling our dress rehearsal last year. So you may have been aware, if you probably attended some of our town halls last year, we got about 3/4 of the way to implementing it, and then we had to stop based on a decision from our Supreme Court. But in the meantime, it was a good time for us to kind of go back to the drawing board and see how we can improve upon this model and make it even better. And there's a lot of things that we identified that we, along with the legislature and the governor's office and stakeholders, we identified that we want to do a little differently this year. So you're going to see some different terminology. You're not going to see a whole lot of managed care organization terminology or MCO. What you're going to see is CE for contracted entity. PLE stands for Oklahoma Provider-Led Entity. And then we have dental benefit managers. So I want to talk a little bit about what a provider-led entity is and how that's different maybe from a contracted entity or a commercial plan. One common theme as we had discussions around a new service delivery system was that we want companies to provide this level of care for our members that are Oklahoma based. We want Oklahoma provider input. We want Oklahoma companies doing this. We want to be able to call an Oklahoman down the street and complain if we need to, or work with them directly, because we know that each state has very unique needs for their membership in Sooner Care and Medicaid. And so we want to be able to address that on a local level. So what an Oklahoma provider-led entity is an organization that is either majority owned or majority governed by Oklahoma providers. That could be physicians, hospital systems, a various lists of providers that are contracted with Sooner Care to provide services. You're going to see SB 1337, that stands for Senate Bill 1337. That was the legislative vehicle that gives the Healthcare authority to move forward with Sooner Select. And it gave us a lot of good direction, a lot of good detail on how the program will be designed. One of those requirements is that we award at least 3 statewide contracts to deliver the service delivery system for the medical component. Now, I did mention earlier, we have dental benefit managers. I should note that we're going to have 3 separate requests for proposals as we build out this program. One will be for dental benefits. We will have at least 2 of those that will be statewide. The next, of course, is the one we're calling the medical, and that's everything except for your teeth. So that's inclusive of your medical services, your mental health services, pharmacy services, vision, all the other things outside of a dental benefit will be in what we're calling the medical program. The third one will be our children's specialty request for proposal, which is a standalone product that is designed to meet the unique needs of our children in the custody of the state, whether that be through child welfare services or juvenile justice services. We know that those kiddos have higher levels of trauma, higher ACE scores. They require more interventions than maybe general population. And so we want to recognize that with a unique product. So we will have 3 statewide for the medical, 2 statewide for the dental, and then we will have 1 awardee for the children's specialty program. It's important to note here that one of the awardees is required to be a provider-led entity if they otherwise meet criteria according to the RFP. This is important, again, because we want to ensure that we have Oklahoma providers are seated at the table making those decisions. Now, the one I've mentioned several times, statewideness, we know how important it is to have a statewide solution for this. There's one limited exception to that, and it's that if a provider-led entity demonstrates that they can meet the criteria of the RFP, except that they're not quite prepared to go statewide, we would allow a PLE only to serve an urban region. We define urban as Oklahoma City or Tulsa areas and those contiguous counties. Now, they can initially serve an urban region, but we will expect to see a timeline that will get that entity to statewideness within 5 years. We've answered several questions around the urban region will not be exclusive to a PLE. So let's say we have 3 statewide options and then 1 PLE, let's say in Tulsa. That just means there will be 4 entities covering Tulsa and 3 entities covering the rest of the state. Expectations of our contracted entities. Throughout the years, we have improved the Sooner Care operations tremendously in order to meet the needs of our provider community. We don't directly provide services, so without our providers, we would be nowhere, right? And so we want to make sure that all those protections that we have baked into the Sooner Care program over the last 25, 30 years remain even as we contract with third parties to administer the program. One of those very important requirements is timely payments to our providers. If you contract with us now, you know that we're fairly quick. If you get a clean claim in by a certain time 1 week, you're getting paid by Wednesday the next week. And that's something you can count on from Sooner Care. And we know a lot of time that steady cash flow is what keeps a lot of the doors open to our providers. And we want that to carry on with our contracted entities. So we have built-in requirements, for example, around 90% of clean claims have to be paid within 14 days. Now, I know that's outside of the 1 week timeline that we currently use, but as we went through this process last year and worked with previous contracted entities for this purpose, I was seeing a lot of same-day payment. I was seeing a week or less. Very rarely did we see anything that was beyond a week. So I would expect maybe in some instances even quicker payments. Along with that is timely response on our prior authorizations. We know that we do not want to create any more administrative burden or a hindrance in our members accessing care, and that means we need to approve those prior authorizations timely, and then our contracted entities need to do so as well. We'll also have very specific quality measures related to improved health outcomes. Again, tying back to one of our initial goals of really moving the needle on a lot of those national outcome standards. So we're going to require all those core set measures within our contracted entity contracts and have specified expectations for where we expect them to be in terms of moving that needle over the contract period. We will also require our contracted entities to submit health data to our health information exchange when it's implemented next year. And important here, this is really important to a lot of our physicians in the state as we built out the program, is that requiring contracted entities to spend 11% of their medical spend on primary care. To give you an idea of kind of a comparison to where we're at today, the healthcare authority's current expenditures on primary care are between 4 and 5%. So this is going to be a big lift, but we know we can accomplish it. And this is over a 4-year period that we would expect contracted entities to get there. We know that by receiving more primary and preventive care, we're going to avoid a lot of those more higher cost, more invasive procedures that members can avoid by having those routine checkups, being able to get into a provider when they initially start seeing symptoms and don't let them worsen to require a higher level of care. So populations, who exactly is going into Sooner Select? Now, I'll let you know, we have several slides on this. We have very distinct populations within our Sooner Care program. The long and short of it is everyone is moving except for our age-blind disabled. Those are the folks that are Sooner Care eligible because of that category. Our folks residing in a nursing home or intermediate care facility will not transition. So that means what's left is, in terms of covered services, this is about 80% of the folks that we serve is our Sooner Care kids, our deemed newborns, our pregnant women, parent caretaker relatives. These are parents at a very low federal poverty limit threshold for income that are taking care of kids on the Sooner Care program. Our new expansion adults, those adults that are age 19 to 64, children in foster care, of course, former foster care kids up to the age of 25. Juvenile justice involved, and children receiving adoption assistance. Our American Indian and Alaska Native population are eligible and welcome to join Sooner Select, but they have the option to opt in if they so choose. They will not be a mandatorily enrolled population, but we welcome their engagement in Sooner Select. So who's excluded? Like I said earlier, our dually eligible individuals, that's our folks that have dual Medicare and Medicaid coverage, age-blind disabled, individuals enrolled in a Medicare savings program, nursing care, level of care. We have a presumptive eligibility period. Those folks will not go to Sooner Select. We have a very small covered TB-related services that will not go. Our BCC population will stay with us to manage, as well as those receiving services under a 1915C home and community-based waiver, like Advantage or the DDS waiver. Those undocumented persons eligible for emergency services only. We have an Insure Oklahoma employee sponsored insurance program that will stay under the administration of the Healthcare Authority, as well as our coverage of the unborn child through our Soon to Be Sooners program. So what's going to be covered under Sooner Select? What covered benefits can we expect to see? I will say if there is a service covered under Sooner Care today, those services will be mandatory for our contracted entities to provide and reimburse for. Now, the great thing about this, going to the service delivery model, is there's a lot of things that a standalone Medicaid agency that operates in a fee-for-service model simply can't do because of federal regulations. We pull down federal participation, federal dollars, when we pay for, as a fee-for-service state, those discrete treatment services. So I mentioned earlier, if we pay $50 for a service, we put up the state's share of that, and then pull down about 67% of the rest of the remaining reimbursement from our federal partners. Because of that, we don't have a lot of flexibility in how we spend those dollars. So we know that in order to truly impact someone's care, you have to really focus on those social determinants of health. Those things that affect us on an everyday basis. Those things like, I don't have access to fresh foods in my area because I live in a food desert. That's going to affect my everyday health. That's going to have impact on my weight, my ability to lose weight in order to improve my other health outcomes. We know that healthy foods can help with the, diabetes rates and such. That's not something we can currently pay for. So that's what we're expecting from our contracted entities to do through our creative payment arrangement with them. They will be able to reinvest any savings they achieve back into our populations by investing in social determinants of health. That means partnering with community-based organizations or social service providers and doing things like employing community health workers in our communities to really work with our members and have boots on the ground that can really help navigate not only the healthcare system, but also where can you find some of those fresh foods. We would expect community events from our partners where they can help make that linkage. We, as I mentioned earlier, of course, the physical health, behavioral health, and pharmacy benefits will all be carved into Sooner Select. So that will all be part of the benefit through Sooner Select. The dental benefits will be provided through a separate contractor, different plan, through a dental benefit manager. But we will expect that those plans will talk to and coordinate with each other, such that, let's say there is a dental condition that is such that it can't be reasonably handled by a dentist because it includes more hospital-based services. We're requiring a level of coordination between the dental plan and the medical plan to make sure that that's a seamless transition and experience for our members. So I mentioned the first bullet already. The second bullet there goes to value-added benefits. Again, this goes back to those things that we can't provide as a fee-for-service Medicaid agency, but they can through our payment arrangement. And that's those services that focus on health and wellness and independence of our members to advance our objectives of moving those health outcomes into a better direction. An example we commonly use that we've actually seen happen is we have great data through claims data. So we can drill down into our claims data and know that we have a member that goes to the emergency room 3 times a day, every day for 2 weeks. We can look at that and we see that and we're like, what's happening there? But we don't have the resources, nor can we use Sooner Care dollars currently to go into the community, figure out a creative solution for that member. What we've seen managed care plans do is they can reach out to the member, say, kind of what's going on. Find out that, it's during the summer. It's like one of the summers we had this year where it was 110 degrees outside, their air conditioner is out, and they were simply going to the emergency room to be seen. Maybe they have an increased pulse rate because it's hot in their home. Something they can do is buy a window unit, make their home more comfortable, prevent them from going to an ER because a $500 window unit is going to be a lot less costly than one ER visit, much less several times a day for multiple weeks. Going back to covered benefits, of course, vision, our durable medical equipment, transportation through Sooner Ride will continue to be administered, but through the Sooner Select plans, pharmacy, and physician services as they currently exist. Another added benefit is that level of care coordination that we're going to expect our plans to provide. The Healthcare Authority has a great population care management division now, and they do amazing work with the populations that we serve. Going back to resources, we have resources to really focus on our chronic care conditions, and we do a great job with that and improving health outcomes, but we're going to take this to the next level and really expect our contracted entities to do that lift for us across all of our populations. So they will come in and have a health risk screening. We'll be able to identify those needs that they need met in order to improve health outcomes, and then meet those needs within our abilities to address them. Going back to pharmacy, we have a preferred drug list that we use currently that will still be managed by the Healthcare Authority, and then reimbursed. Those drugs will be reimbursed through our contracted entities. We currently participate in a rebate program where we receive drug rebates from the manufacturers, and those savings come back to the Healthcare Authority for us to reinvest into our program in other ways. That will still accrue to the benefit of the Healthcare Authority. And again, we will ensure that our members have access to non-emergency transportation using our current network standards that we do today. Speaking of network, an important piece of the Sooner Select program is network adequacy. So what that means is, as we move forward, we want to make sure that each of our plans, and not only do we want to ensure, but also our federal partners are requiring us to ensure, and they will check us on this, that each of the plans have an adequate network for providers. That's all providers that we contract with today. So essentially, if there's a provider type that the healthcare authority contracts with today, we will expect to see a level of involvement in contracting with those same set of providers with our contracted entities. And they have to have enough of those providers to satisfy us that they have enough per member in their area, and they're going to have very specific time and distance standards. So for example, if you are in I want to say an urban area, I think we're going to expect to see a PCP within 5 to 10 miles of a member's address in that area, or within a certain mileage distance. And we're going to have variations on that depending on if the area is urban or rural. But we've been pretty strict on these, I will admit, in our RFP. In some cases, we're expecting access to providers that we're not even able to provide as the healthcare authority now. So this will be a crucial component in moving forward. And as I mentioned, the network adequacy is something that our federal partners will really hone in on during the readiness review period before they tell us we can go live. All right, let's talk a second about quality and population health. So I mentioned earlier that, of course, one of our main goals is to really ensure that quality is included in everything that we do through our new Center Select program. One of the tools in our toolkit that we'll use is our external quality review organization, which is actually a federal requirement that every managed care state have one of these organizations. We have one on contract now. We did last year. And so we have been eagerly awaiting to go live. And so they can assist us with doing these external reviews and really using them and their third-party expertise to really take a deep dive into our programs and make sure that they are doing what they told us to do in external validation. We'll also have ongoing comprehensive quality assessment and performance improvement programs. We will do annual consumer assessment of healthcare providers and systems survey, otherwise known as CAPS. We did actually our first one this year as a Medicaid agency. It's very rare that non-managed care states do this, but we wanted to go ahead and get ahead of that so we can have good baseline data going in that we can kind of compare our plans to versus what our baseline started at. Each plan will also be required to do 3 performance improvement plans on an annual basis. So this will be something that each plan kind of wants to focus on that is kind of innovative, maybe diagnosis specific, something that they kind of want to test to see if there's good health outcomes so that they can then incorporate into their overall plans moving forward. Each will have to do 3 annually. They can choose some, they being the contracted entities, and the healthcare authority and our partners can also have some input into what those PIPs are on an annual basis. We will also have a quality advisory committee. This is required by Senate Bill 1337, and we're glad it is because it's a great idea. This committee will be comprised of, between 12 and 15 members, and it's going to be a good cross-section of our provider community. So providers, stakeholders, those with expertise around health outcomes and quality. We had an open kind of application process so that if people were interested, that unfortunately ended September the 9th, and we're currently in our process of going through those lists. I want to say it's from between 45 to 50 folks expressed interest. So we're currently going through that list and identifying those 12 to 15 individuals that will serve in that community. But the real purpose is for them to meet on a regular basis, again, subject to the Open Meetings Act, and really help us drive those, again, the PIPs, the quality outcomes measures that we want to put in the contract, for example, those things that we're expecting to see from our contracted entities in terms of quality, and really relying on our community to help us inform that. I kind of went over this. Also, if you get on the committee, it's important to note that we cannot give you any compensation or travel reimbursement, but we appreciate your service nonetheless. All right, let's talk about the provider incentive pool for a second. So we actually had 2 legislative authorities go through at the same time last session. One was 1337. The companion bill to that was more of the financing bill, Senate Bill 1396. 1396 gave the healthcare authority a certain authority to change the way we calculate our SHOP payments. So SHOP stands for Supplemental Hospital Offset Payment Program. It's a supplemental payment that currently goes to our hospital network based on certain factors that we use to calculate the amounts. But essentially our hospitals put up, they front dollars through a fee that they then give that fee to the healthcare authority. We use that fee to then match federal dollars from our partners at the federal at CMS, pull those dollars back down, and then redistribute the dollars to our hospital system such that it's an enhanced payment on what they would have received. Now, the way we calculate that is fairly complicated, even more so for me to fully understand, but we have a certain pool of money we can use. And that pool is the amount we paid our hospitals at the Medicaid rate is the floor. The ceiling is what Medicare would have paid the hospital for the same or similar service. The gap between the floor and the ceiling is the pool of dollars we have to use for that. We're currently maxing that pool out for our SHOP program. By going to a managed care service delivery system, federal regulations say that we can change the way we calculate the ceiling. So we go from what Medicare would have paid for that service at a hospital up to what an average commercial rate would have been had a commercial payer paid that in the state. And so, as you can imagine, a commercial rate's even going to be higher than Medicare. And so we have the opportunity by adjusting this program through Senate Bill 1396 to bring in between 500 and 600 million additional dollars into the Oklahoma healthcare system on an annual basis. So we are currently in the process of defining how we will calculate that, how we will distribute it back to providers. One important thing here to understand is it's not just going back to hospitals once we do this. These additional dollars will also be reinvested into our primary care physicians, other community providers, providers not associated with the hospital, for example. And so we are in the process of working with stakeholders, very capable consultants to arrive at how do we calculate that, how do we distribute it, and how do we separate those pools of dollars to ensure that we're making those investments where we should. All right, I mentioned capitated payments earlier. This goes back to that ensuring cost predictability for the state. As I said earlier, as a service comes in, we pay it, and there really is no ceiling on that in our current environment. By going to this to Sooner Select, it will be a fully risk-based capitated contract approved by the Centers for Medicare and Medicaid Services. We are working with an actuarial firm that's doing that for us. So basically what they're doing is taking historical data based on historical Sooner Care population utilization based on claims data, breaking all that service utilization down by population and creating per member per month payments for those individuals in those categories of population that we will then pay to the contracted entities. So instead of us paying a claim fee for service, we're now going to take those dollars. And if, let's say, I am aligned with contracted entity number one, the healthcare authority will pay contracted entity number one a certain amount per member per month for every service they're providing for me. Of note here is also our withhold agreements. This kind of ties back into our quality strategy. We know that there's multiple ways of incentivizing behaviors for contractors. This is one of them. What we will do is say, okay, contractor, we have all these things that we want you to do in this contract here. We're going to withhold 1% of your capitation payments up front. And once you've demonstrated that you have met those requirements that we want of you around quality initiatives, we will start giving you those dollars back. So it gives them an opportunity to meet those performance measures and then earn some of that money back on the back end. So payment rates and timeline. So I just talked about kind of the payment arrangement between the healthcare authority and the contracted entities. So this is more around what does the payments look like between the contracted entities and the providers and you. So we want to ensure, and we did ensure through Senate Bill 1337 as well as through the RFP that's yet to be released, but we're requiring reasonable provider rates. One of those protections is that rate floors will be in effect for providers until July 1st of 2026. So essentially, the rates that a provider is receiving on a fee-for-service basis from the healthcare authority the day before we go live, those same rates will stay in effect until July 1st of 2026. Now, this is important for many reasons. A, we know there's potentially anxiety about going to a new service delivery system. I know there's a fear of reduced rates, reduced services. And to address that, we put in these protections. And the reason that 2-year is there is because we know that going from a fee-for-service environment to a value-based environment is going to take time. And it's going to be a learning process, and we want that to be gradual, and we want to allow adequate time for that before we really expect to see a value-based payment agreement between our providers and the contracted entities. Now, I know, I'll go ahead and address what does that mean? What's a value-based payment? How do we get there? What should we expect? We're creating a very gradual glide path to get to the requirement of value-based payments. So I would expect to see something like the first few years from a provider perspective we're not expecting that you're all going to cure the heart disease rate among Oklahomans in years 1 and 2, or even 5. We know that's going to be a long runway over many years for us to get there. What we also know is that there's a lot of small incremental steps that we can all take together around maybe even reporting. I know there's a lot of providers in our network that are doing really good things, but we don't know about it or can't see it because it's not collected through some kind of a reporting mechanism. We know reporting mechanisms can be administratively burdensome. We know that they can take extra time out of our days when we're already busy seeing our clients. So to incentivize for that, an early value-based payment methodology could be, hey, provider, if you have invested in the architecture and the IT software and the time to start reporting, there's an incentive for that. So that's what we're going to expect to see from the healthcare authority standpoint, is that our contracted entities are investing that into our provider community so that once we get to the expectation of that you're improving health outcomes many years down the road, we will have gotten you to where you need to be in order to do that. There are certain federal protections for some payment methodologies that will continue forward. That's federally qualified health centers, rural health centers, the way we pay pharmacies and pharmacists, Indian healthcare providers, and our emergency services. Timeline. So this says fall of 2022. I will say that we did release the dental RFP on September the 1st. Those bids actually close, I believe, Halloween Day. We expect to get the medical RFP out at some point in October. We have a team that's diligently working on that right now with the help of some consultants. And so we expect to have that out this month. We will have a 90-day response time from release for those potential bidders to get to bid back on that. We're expecting award of the medical RFP probably sometime in April of 2023. We do have an anticipated launch date to go live with Sooner Select in October of 2023. But important there is to note those the last few words of that sentence is pending CMS approval. So at every step along this process, whether it be our contracts for our RFPs, our actuarially set rates, our contracts, our network adequacy standards, our readiness review, all of this has to go to our federal partners for them to also review and approve or help us get to where we need to be. And we know that takes time. So it's very possible our launch date could be after October, but that's what we're shooting for, and it's what's required of us by Senate Bill 1337. All right, so we'll have some Q&A. I will say that there's just shy of 300 folks on, and I know we're not going to get to every question. I will also acknowledge that thanks to the folks that went ahead and sent in questions prior to the town hall. Again, we probably got around 50 of those, and just because of time, I'm not gonna be able to get to all of them, but we will spend time internally answering those, and our communications guys will put those on our website within probably a week or two. So you'll have access to that. Okay, so let's see, in the Q&A, pardon me, I'll be looking at another screen. We have, what if a provider can't credential with any of the private insurance managing organizations? And so I will say that a commercial plan as it exists on the market today is not going to necessarily be an apples to apples comparison with a commercial plan that is contracting with a Medicaid agency. So there are a lot of federal protections, one of which is non-discrimination against providers during contracting, which actually includes, let's say a provider is not board certified, for example. There's protections in federal law that we will have in the RFP that specifies they cannot exclude a provider based on that. Question around what is the definition of primary care? Great question, and one we're asked a lot. So when asking to expand spending to 11% of medical spend, will it include a broad definition including multidisciplinary care like care management, dietitians, Let's see, physician APP definitions. Good question, and we don't know yet. It's funny as we go through this process, one would think it might be pretty obvious what definition of primary care is, but it gets very nuanced. And so we are working with that again with our stakeholders and provider community to define what that is. It may include other disciplines, not just medical, but it's definitely going to be aimed at those primary preventive type services, but still yet to be determined. But we will definitely keep you updated as we go along in that journey. How quickly must contracted entities approve credentialing applications for new contractors? Great question. It's something I actually failed to mention. Going back to, we understand there's going to be concerns around increased administrative requirements for providers that they aren't currently subject to now. One of those is contracting and credentialing. Right now, you can submit an application to the healthcare authority, and our general turnaround time for that is in anywhere between 4 to 6 weeks. Doing that with multiple organizations can kind of seem pretty burdensome at sometimes. So what we've done for that is we're requiring that all of our contracted entities use one centralized credentialing organization that will do all the credentialing for all the plans. So you just have to do it once rather than filling out one for one contracted entity, another, for the others, potentially 4 or so. So you'll do that once with whichever credentialing verification organization is chosen by the plans and approved by us. We do have, I'm not recalling exactly what they are, but we'll make sure we get that in our written Q&A. We do have very specific turnaround times or expectations for not only credentialing decisions, but also contracting decisions. Will chiropractic care be considered a covered service for Sooner Select members? Yes, so that goes back to, if it's covered by Sooner Care today, it will be covered by our partners. Now, we do cover chiropractic care in limited circumstances. It's more as an alternative benefit for pain management currently. Now, that can be a value add. Let's say that one of our partners decides that they want to provide or reimburse for chiropractic care more generally, not just in that limited circumstance. That's definitely something we would allow in a value added benefit. If a child receives SSI or Social Security income, are they included in the ABD or Sooner Select? Receiving SSI is tied to ABD, I believe, and so no, they would be excluded. Will there be future opportunities to apply or join for the Quality Oversight Committee? I imagine there will. As with any committee, when they initially meet, there will be bylaws established and term limits established, and when those expire, we have to kind of set that up on a rolling timeline so that we don't lose the entire committee all at once. But yeah, as folks term out or choose not to serve anymore, we will definitely open that back up for application. Due to what you mentioned about accepting the private insurance rates, which are often lower than Medicaid due to the ability to accept a copay and insurance, will we now be able to also accept copays and coinsurance to fill in the gap? So let me clarify. When I mentioned commercial rates, that was only with regard to that upper payment limit for our supplemental payments. They are our contracted entities will still use the fee-for-service schedule that the healthcare authority uses for the first 2 years, and then it could be more, or they could supplement it with a supplemental payment based on how well you're doing with that value-based agreement that you've entered into with them. But also to answer the other questions, no. Federally, you can only charge the nominal copays that's currently allowed, which I think goes up to about $4 for Sooner Care members currently. Question, so will there be software available to purchase to help with the reporting? I would say that's yet to be determined. It will be up to the contracted entities to assist you with that. They may have their own portals that they want you to use, that maybe they could be at no cost to you. A lot of this stuff is going to be worked out between the contracted entity and the provider themselves. I will also say a lot of what we're going to learn about the contracted entities and the things they provide, we will learn during the RFP response process. So some of it kind of stands to, we don't know yet, right? So we'll have to wait till they respond and see what they do before we know all these answers to the questions. How does this affect mental health and substance abuse private agencies? I will say that our private behavioral health agencies are currently in the Sooner Care Provider Network, and they will also be in a Sooner Select Provider Network. Have the MCOs been identified? No, we won't know that until March, April of who they actually are after we've been through the entire evaluation process. Will members be able to move in between plans, and if so, what time intervals? So we're differentiating between implementation and steady state. And so we will allow up to 60 days prior to Sooner Select go live. So let's say now we're go live is October of 23. We'll allow 60 days before that. We'll allow them to start providing and picking a plan. Once you have picked a plan, you'll have 90 days to change your mind and you can go to another one. At that point, though, you must remain in that plan for the rest of that enrollment year. After that, you can choose another plan during open enrollment, much like private commercial insurance today. Are you prohibiting vision plans from being utilized with the medical plan? Samples we've been sent are showing that's not the case, and reimbursements on materials are cut in half. Again, no, we're not prohibiting vision plans. It was yet to be seen because we're not in the evaluation process, what's being proposed. But contractors are free to provide vision directly, contract with local Oklahoma provider organizations to administer the vision benefit or other subcontractors of their choosing. Now, I will say that has to be approved by the healthcare authority. There's very few things, if any, that a contracted entity can do that does not require our approval before they do it. Will the payment rates be different from Sooner Care versus Sooner Select? I think I've addressed. How will newborns be added to the various plans? Will they be assigned to a plan date of birth? How frequently can the plans change? I think I addressed how frequently they can change. Yes, I mean, they won't. In that case, we will have a very, and I'll say we'll probably provide more detail in written Q&As. But yeah, generally the newborns will have a Sooner Care ID. We'll go ahead and pay for that global payment for the delivery. Parents will have the choice of then choosing that plan. If they don't, our auto assignment algorithm wants to keep cases and families together and aligned with the same provider. And so we'll ensure that the family is kept on the same plan. See, will providers have a way to distinguish between a fee-for-service member and someone who will be in Sooner Select? For example, an adult caretaker with child versus an adult of the same age who has been declared disabled by Social Security. You will, but in terms of members on Sooner Select will have a card, an ID card that will show the name of the plan that is administering their benefit. Others will have typical, as you would see today in the provider portal. I will also say another thing that we have built in terms of helping reduce administrative burden on our providers is that we're requiring that all of the plans work with a single front-end portal that a provider works with and views. So in terms of receiving your remittance advice, submitting claims, submitting prior authorization requests, that portal will be the same for you, whether it's plan A or plan D. Now on the back end, you may have to choose the plan that they're on based on the eligibility information given to you by that portal, but all of it will be sorted out on the back end. So it's more of a seamless process for the provider. Question, does this apply to mental health services? Yes, all services are carved into Sooner Select. When can we begin contracting efforts with plans that may be awarded membership? Will value-based reimbursement be required in pediatric hospital agreements or other models permitted? So I will say that the plans that are planning to bid over the next few months, you may have already met. They are probably in the community trying to get letters of intent from our providers, so that during the bidding, the evaluation process, they can have they can start demonstrating network adequacy. Now, those letters of intent are just that. They're not contracts. They can't technically be a contract with them until they have a contract with us. And so I would say after award, which again is in more than likely April of 2023, that's when they will really start hitting the ground wanting to convert those letters of intent into an actual contract. Or if they haven't visited with you yet, we would expect for them to, at that point, to establish contract relationship. Can you talk about the plans to move forward providing providers being paid a capitated rate by the MSO and MCO in the future? It seems like there was language about this in Senate Bill 1337. Are there incentives for this, a timeline, a way to allow some providers to do this and others to remain fee-for-service through the MCO? Kind of goes back to, well, I'll address the first question. There is no requirement that a contracted entity pay a participating provider using a capitated methodology. The capitated rate is the relationship between the healthcare authority and the contracted entity. What we do expect to see is value-based payment methodologies at certain intervals throughout the contract life between the contracted entity and the participating provider. Now, I will say that this is going to be an agreement between you and the contracted entity. Value-based payments can look different by provider type. It can look different among providers within a provider type or specialty. And it's something we're going to learn a lot more as we go down, because different plans may have different ideas about how to achieve the goals of the program. How does pediatric therapy fit into this model of value-based care? Each child is so different and has other extenuating circumstances that will impact their outcomes. Is it possible for pediatric therapy to stay in fee-for-service? Again, it's going to be up to the plans. I will say, as I described the value-based payment glide path earlier, it's going to be a lot of early on reporting those things. I think I mentioned this at the last town hall. I'm sure a lot of our PTSD OT pediatric providers are providing great service, achieving good outcomes. We just don't know what they are right now at the healthcare authority level because we don't have those reporting mechanisms in place. So there would be a hybrid model of fee-for-service plus supplemental payments based on how you reported and what those reports look like. If a patient requests a PCP outside of the 5 to 10 mile radius in an urban area, will that be allowed? Yes. So the time and distance standards are just a way for us to measure network adequacy with the plan. Now, if I live in Oklahoma City, but I really love my primary care provider in Woodward, I can choose that. A care coordinator may advise against that unless they have a great telehealth setup that I can meet with them regularly without driving to Woodward. But yes, I can choose a primary care provider or specialty throughout the state, and that's my choice as a member. What happens after July of 26 when the rate floors are gone? What can we plan for? We will see plans for this when our contract entities bid. Again, the purpose of the rate floor was to ensure that a successful transition and a successful time to get to value-based payments. When can we expect an increase in reimbursement rates? It's been over 5 years since we've seen an increase, and all providers are battling inflation. I will say this is outside of the Sooner Select conversation. So we will put this in the parking lot to address outside of this forum. I've answered the mental health question. Will providers need to be enrolled as a Medicaid provider prior to submitting an application to the CBO? That's a good question. Let me respond to that in writing. I don't think so. It's going to be, you will definitely have to do both. So you will have to submit a contract to the healthcare authority and go through our provider enrollment screening process. And you will also have to be credentialed through the CBO. You have to do both. I'm just not sure which comes first. Will CCBHC still receive PPS? So for those of you who don't know, that's Certified Community Behavioral Health Clinic. It's a service delivery model in the behavioral health community mental health network. And they receive a prospective payment system rate, which is a monthly rate, which is all inclusive. It's very similar to a capitated payment of the services that community mental health center provides. And yes, that is required not only in the contract, but is required by Senate Bill 1337. Will orthotics and prosthetics be covered under Sooner Care for patients over the age of 20? If it's a covered service now, it will be covered in Sooner Select. Our IHS, that's Indian Health Services contracts, included in Sooner Select. Yes, there's a few nuances there. Our tribal partners, our Indian healthcare providers, they can get paid in a couple of different ways. So if there is a qualifying American Indian Alaskan Native that seeks service at an Indian healthcare provider, we pay that provider, it's called an OMB rate. It's all-inclusive daily rate for the service received there. Now that's 100% paid for by the federal government, but it comes through the healthcare authority. In those instances, the healthcare authority will still pay that directly to the Indian healthcare provider. That will not go through the Sooner Select provider. Now, we also have instances where an Indian healthcare provider can provide services to a non-native member, at which point they get fee for service. And that would go through Sooner Select because that non-native member, unless they're otherwise excluded from Sooner Select, would have a Sooner Select plan. But yes, there are requirements for network adequacy when it comes to our Indian healthcare provider network. Let's see, it sounds like there will only be a small amount of contracts awarded across the state. Does this mean that all medical providers will now have to be working for these massive health service companies such as Integris? No, it doesn't. Can you tell me again who fits into the children's specialty group? Is there only, let's see that they're moving around, sorry. Is there only one group that will accept all children? So all of our kids that Sooner Care serves now, the bulk of our population, will be served through Sooner Select. Those kids will have the choice of any plan they want that their parents or guardians choose for them, except those kids that are in the care and custody of the state through Child Welfare Services or Juvenile Justice Services. Those kiddos will be served by the Children's Specialty Plan, which is a single statewide plan to coordinate and meet their unique needs. At last count, I want to say the total population for this would be around 27,000. That's inclusive of those post-adoption kids, those that are former foster care kids, aging out, and those in the custody. Those kids will be served by the Children's Specialty Plan. Will clients be allowed to be seen by approved by a provider outside of their assigned provider? So I will say that if they are in a plan, so maybe this is more applicable to the initial implementation. Let's say they have a provider and they're in a plan where their primary care provider, for example, is not a contracted provider. There is a certain runway they're built in during the transition plan, during implementation, that the plan have to pay that out of network provider during the transition. And hopefully make an attempt to help that contractor be a participating provider in their plan, after which it's going to be an out of network provider with different payment methodologies for an out of network provider. Let's see, will adult dental coverage be expanded more? So I will say we had a fairly robust expansion of our adult dental benefit last July. Anything above and beyond that at this point would be a value added benefit by the plan themselves, which is at their discretion. Will the plans move to the commercial insurance model that was presented last year with BCBS, United, and Humana options, or will the insurance itself look the same as it does now, continuing to use H codes for billing rather than commercial CPT code billing? I'm sorry, I'll have to defer this one to written question and answer. How will specialists be affected by this change? We would expect all of our specialists, again, if they contract with us, they are within the network to be contracted with a plan moving forward. We lack a lot of specialties in Oklahoma, so I know it's going to be hard to meet the network adequacy standards for specialists. So I would expect the plans to extend contracts to the majority of the specialist network in the state. When will the change take place for mental health and substance abuse? It's all taking place at the same time. Question around the children's specialty bid. Will it be standalone RFP? Yes, it will be standalone this time. Last year, it was more of an addendum to the overall medical RFP, but it will be a standalone plan. Let's see. Will the question and answer section also be available for review? Yep, we had some submitted before this, and these will also be tracked, and our team will work on answering those to hopefully get posted on our Sooner Select page within a week or two. We are an Advantage waiver DME provider, and you have said that the ABD population will not be included. However, there are changes implemented in 2020. All continence orders must be submitted to the Medicaid state plan. That's an ABD population. Those members are not going to be administered through Sooner Select. There's a question asked us to submit this presentation to a particular person. I will say that this town hall is being recorded, and I believe there's closed captioning with it as well. That will be posted to our Sooner Select webpage on the public site. See, in the past, we haven't had any settlement with OHCA since there's no Medicaid cost report filed. In other states, the Medicaid managed care, the plans each have a settlement that runs through a specific section of the Medicare cost report. Will that be the case going forward? That's a very nuanced question. I would have to know what type of provider, who the provider is, what the costs are. Happy to try to address that through written if we have more detail. Can you clarify if a provider is unable to be in contract with private contract or contact with private insurance now, will that an issue with Sooner Select? I'll have to defer to written to unpack that question a little more. There's a question about Advantage waiver. Like I said, in general, that population is not moving to Sooner Select. We can resolve that question. Mr. Palmer, I will also resolve yours in written Q&A. Thank you. Nice little compliment there. I appreciate that. So we appreciate everyone's attendance. We're currently at around 240 attendees, and we're glad that these are working. We're hoping that they are helpful for you and answering a lot of the questions. Again, this will be available on our Sooner Select site. We'll go through and have written responses to all of these questions for you to look at your leisure after this. We also have another town hall coming up. I want to say it's October the 5th, but maybe one of my team members can put that in the chat to let everyone know when the next town hall is, so you can tell your friends and colleagues in case they miss this one. We appreciate your participation, and we will talk to you soon.